Let me share my screen. And then also I invited one of my colleagues, Claire Quiner, to join me in presenting to you guys. She has some really awesome work. And I just can resist the opportunity to show some of that off. But yeah, I'm Megan Lindstrom. I am a through and through geographer, all my degrees in it, and I self-identify as a spatial epidemiologist. So I look at why people get sick where they do. And then Claire, I will let you briefly introduce yourself as well.
Thanks, Megan, and thank you for the invitation. My name is Claire Quiner. I'm an infectious disease epidemiologist. I wish I was as good at spatial analyses as Megan is, but I'm not, but I do dabble in it. I'm particularly interested at the interface of changing world patterns such as climate change, urbanization, globalization, etc., and emerging and zoonotic infectious diseases, which you'll hear a little bit about today.
Awesome. Okay, so we have a couple examples of how we do this in our current work. The first one I'm going to cover is let's move that slide forward, is avian influenza. And so Claire and I were asked to be part of a team at RTI earlier this year, maybe part of last year, to respond to some of the avian influenza outbreaks that were happening across farms and then transferring to farm workers. And so we really wanted to build this with a One Health perspective because we have this environmental condition where people are coming into uh, contact with animals in farms, and then farm animals are also in contact with wild birds. So we have this very interconnected system, and we built it around that. And then also a response to the National Academies of Science, Engineering, and Medicine that said, we have these outbreaks of avian influenza and we are missing these key gaps, which is how the virus comes into the animal populations, mechanisms of spread, routes to humans, and then also solutions. So, like, how effective are some of the practices we currently use, like culling herds, and then also methods for continuing testing and surveillance. So, all of that is a lot to expect from data and modeling capabilities. So, our team came up with this conceptual framework where we mashed together multiple models through data integration practices so that we could get at the heart of that One Health framework that was driving the spread of avian influenza. So, how this worked was it started with NADSM, which is an animal model. And this animal model allows us to model the duration of disease or avian influenza in particular, the potentials for spread, control measures. So, what happens if you do cull a herd? And then it can let you toggle species and production types. So, we have this animal model. It's doing all of this work, but we know that it can transfer from animals to humans. So using something called SynthPop, which I'll cover in the next slide, we can match that to human populations that are nearby and use a model, this is an individual-based model called Cassandra. And it identifies social networks among human populations to figure out how diseases spread. It looks at interactions. It can even handle long distance travel. And then again, it identifies those control measures. So we have these big models with lots of data, but how are we connecting them across space? And how we're proposing to do this is through synthetic populations. So synthetic populations are point level data that can be either human or animal. We have both. And we can use that to connect to non-spatial and other spatial data. So we created it using algorithms and the statistical methods that backend into the US Census data and also the agricultural US Census data for animals. And so it also pulls in things like household size, race, income, ethnicity. And then it plops these households in census tracts. And while that could be completely random, our team uses land use and land cover remote sensing data to make sure that we're assigning locations of households to actual points. where there are likely to be people. So, for instance, you can see in this image of the human one, we are not putting people inside this state park because they are likely not living there or on top of this airport. Instead, we're making sure that we're assigning humans to where they actually probably live. And that was similarly done here with hog farms. So, I'm sure everyone here can see where this is going, that we can really use these point level populations to connect it to anything that is already geographically referenced. So we can use climate data, more land use, land cover, other remotely sensed data, social determinants of health at any granularity. So we can pull in stuff that is mismatched, different years. So it's really useful to have that point level data. And then what's even cooler is that because we build this synthetic population, specifically for humans, with census data, it has ACS variables connected to it. So then we can bridge that out even further and match people to records from things like NHANES. So then we can start connecting health data. So it kind of, it really opens this broad horizon of connecting surveillance data that previously has very little geographic information to potentially matched populations, so we can simulate what's going to happen in a true, um, a true case or scenario. But I'm going to move forward and talk about, or have Claire talk about some stuff that she's actually done, move beyond the conceptual framework of these kind of integrations.
Thanks, Megan. We worked here at RTI in a study called the Surveillance of Acute Febrile Illness Across Nigeria study, or the SAFIAN study. And in this study, we enrolled 1,200 participants from two different hospitals in Nigeria. And we screened their sample for 24 different infectious diseases using a tool called the Thermo Fisher TAC card. TAC is kind of an unusual or it's an unusual tool in that you can simultaneously detect, again, up to 24 targets, molecular targets from a single sample, which is a number that's otherwise cost, time, and labor prohibited. So if you go to the doctor may, and with a certain set of symptoms, the doctor may test you for one or two things, or perhaps a panel of things, but you probably won't get tested for 24 infectious diseases, even if you have an acute febrile illness. We were left with the question, this is a customizable tool, so we were left to decide which molecular targets to include in this surveillance study. That posed a bit of a conundrum when we were thinking about which pathogens to actually screen these patients for. We noticed that other multi-pathogen studies, such as this one, really provided minimal details about how they made this decision. And we also noticed that those other studies commonly included pathogens that had known endemicity within their respective populations. We really wanted to, for this study, take into consideration the globally changing landscape, the things that are leading to emergence and introduction of pathogens in locations where they previously were not. Within recent memory, all of us can recall an unexpected emergence of a pathogen in a location which was unprepared to recognize, diagnose, or respond to it. Ebola virus 2015 into Western Africa, for one example. Plasmodium is now popping up in Florida, Texas, and Maryland. It was previously mainly isolated to tropical and subtropical regions. And then Nipah virus in the late 90s was introduced into Malaysia and Singapore in very catastrophic ways. So we wanted to kind of use this study to try to think about how we could use it to detect pathogens before they became a major public health crisis. Um, so if you could click, I've got an animation there, Megan. What we did is we developed, and I'm sorry, just focus on the framework on the left to begin with. We developed a framework for assessing a pathogen's transmission potential in a given region. Now, the first step was just to look to see if the pathogen had ability for human to human transmission. If the answer to that was yes, then the pathogen was deemed to have a transmission potential, and it really could be detected or transmitted in any region of the world. even if it originally emerged in a different part of the world. We all have great experience with that with the SARS-CoV-2 pandemic. Can you, okay, and then the next step to this framework, parameter two, was to look for previous human cases of a pathogen within, in this case, Nigeria or any region of interest. And this was to say we're trying to figure out if it's already being transmitted there. This was specifically limited to humans. We were wondering if there'd already been human cases in that region. Now, if the answer to that parameter was no, then we went on to assess for parameter three, and that is we haven't found any confirmed cases in humans of this particular pathogen in Nigeria, but has it ever been detected in human and insects or animals? And if it's in humans, insects, and animals, then we know that the pathogen has some transmission potential there. It just maybe hasn't jumped into the human population, or perhaps it has and just nobody's caught it yet. Nobody's tested for it. There's some additional details about the type of detection, if it was molecular or serological. I can go into that if anybody's interested in it. Um, Parameter four, if the answer to parameter one, two, and three were no, then we assessed for parameter four. So this is in the paucity of previous detection in humans, animals, and or insects. There remains a potential for the transmission of the pathogen if its vector, host, or reservoir is present within that region. So I'm going to start talking a little bit more about data here because I know this is the data crew. To assess this parameter, we used ecological surveys, in this case, Nigeria, studies of realized host ranges, gridded data of livestock or other animals or other animals to assess this parameter. For the last parameter, if neither the pathogen nor itself, nor its vector and or reservoir had been previously detected, the final step of this framework was to determine if the ecological requirements for the vector or reservoir are present. This parameter is assessed through climatic and ecological data and projections of realized versus potential host vector ranges. I also, to assess pathogens for this parameter, really relied on various sources of remotely sensed data, pulling in elevation, understanding where the fresh water sources were, et cetera, et cetera. One thing that I want to point out before I jump into the results is that as you move downward in the parameters from 1 to 5, there's a decreased relative likelihood of detection. So that's just to say that if a pathogen fulfills parameters 1 or 2, that's not all that surprising. But if it's fulfilling parameter 4 or 5, 3, 4, or 5, and it's never been detected in humans, animals, vectors, etc., it would be quite interesting. So when we set out, we thought that we would maybe find one of these pathogens that had never been detected before. Um, uh, and you can see on the image on the right, the names of the pathogens there are the ones that we eventually included in the study. And the ones that are in red are the ones that we detected. So again, starting with parameter one, nobody was particularly surprised that we found a little bit of monkeypox virus, hepatitis E, etc. And in parameter two, those are all ones for which there was previous detection, Plasmodium being a very common one, Brucella, etc. Um, Moving on to parameter three, we found a lot of Rickettsia species, which is a bacterial species. And that was quite interesting because although it had been detected in some livestock, in some animals previously, it had never been detected in humans in Nigeria, or at least recorded. And we found so much of it. There was actually more patients where we detected Rickettsia than they did Plasmodium, which is the pathogen that causes malaria, something that has a known endemicity in Nigeria. Moving on to parameter four, we detected Nyung virus, which is an alpha virus transmitted by certain species of mosquitoes. And then parameter five, we actually found one case of Yersinia pestis, which is the causative agent of plague, which pops up every now and again. Um, so I wanted to focus on the pathogens that fulfilled parameters 4 and 5 to tell you which data and how we decided to include them in the first place. and exactly which data that we use to include them. Could you go to the next slide, Megan? Okay, great. So, young virus fulfilled the criteria for parameter 4. Its mosquito vector, Anopheles fuentes and Anopheles gambiae, are both present in Nigeria. And what really got me excited about this pathogen, I knew very little about it, but we saw that there was kind of some few scant reports of detection of those species of mosquitoes throughout Nigeria. But we saw that they were expected to expand their geographic range under future plans. And that's what we're showing. Nope, that's not what we're showing. So we use that study, the potential distribution of the dominant malaria vector species under different conditions. So that's that reference. We used other people's work for this. But then we supported it with additional information, the bioclimatic variables from World Clim, the global climate models, land use land cover data, and digital elevation model. These are all of the factors that really feed into whether or not a region is suitable for a particular species of mosquito or not. Those are common predictors of it. So it was really just based on those types of publicly available data and how they were organized into models that led us to decide to include that pathogen in our study. And in fact, we found it. Could you go to the next slide? Um, I also want to talk about the evidence for transmission potential of Yersinia pestis. Of course, plague is a pathogen, plague is a disease as old as time, it's almost fair to say that. And it's almost certainly had popped up in Nigeria and nearly other place in the world at some point in time. Um, we were, kind of looking at relatively recent records and of course things that were published in the literature. So we last found any evidence of plague in Nigeria, I think about 40 years ago, and it was only one or two cases. So we weren't really too keen on including it based on that alone. We didn't have much information about those cases. They could have been attributed to a traveler or anything like that. But this other study, Geographic Distribution and Ecological Niche of Plague in Sub-Saharan Africa, developed the potential distribution of Yersinia pestis throughout the continent of Africa based on 45 outbreaks in sub-Saharan Africa and their environmental covariates. So again, on the right there, we have the geodata used to determine this transmission potential. The bioclim variables, again, topographic data, looking at elevation, aspect, slope, compound topographic index, etc. Evapotranspiration, potential evapotranspiration, soil pH, global land cover, and then NDVI values. And those were organized into this model. And we saw that there were parts of Nigeria that were predicted to be suitable for the transmission requirements of that pathogen. And in fact, we did find a case of that. And that was quite unexpected. Nobody could quite believe it. And we are still waiting for clinical confirmation of some of these. But we were quite astounded to have found such a large number of things which are circulating broadly in these communities, which are really going completely unnoticed and unchecked by the medical personnel in the region. Um, and it really is just to wrap this up, it's really because of the available data, the available publicly available data that we use to just say it's not being transmitted there based on what we know, but it could be there based on its transmission potential. And that's what led to this really interesting study. Megan, back to you. You're
I
on
should
mute.
unmute myself. Yes, we'll just briefly wrap this up before we take any questions. So we're hoping that we kind of demonstrated how we like to approach building models and integrating data from all these different places so that we can utilize a One Health framework. I showed you guys SynthPop and how these geospatially referenced data points can be used to, augment data sets that perhaps were not previously geographically referenced. And then Claire did an awesome job of showing how remote sensing data and future projections can help lead us to find emerging diseases across the world. So I will pause and stop screen sharing here and see if anyone has any questions.